I'd like to welcome you to the MIDAS webinar today as part of the MIDAS webinar series. We have MIDAS webinar series every Friday, the last Friday of the month from noon to 1 o'clock Eastern time. And just for those who are not familiar yet, the Models of Infectious Disease Agent Study, MIDAS, it's a global network of infectious disease modelers, many currently working on COVID-19. And for more information on the slide that is showing is the website midasnetwork.us, and there's also a membership request form for those that are interested to join. There are 3 presentations today. It's a little different than usual, but it's very exciting to have 3 groups present their work. Today is about modeling of school reopening strategies. All groups use agent-based or individual-based methods, modeling methods. So it'll be nice to see how they're all did the work. So the first talk will be by Guido Espana at the University of Notre Dame. He will present an agent-based model to determine the impact of school reopening in Indiana. Guido is a postdoc at Notre Dame, working with Alex Perkins in the biology sciences department. Alex Perkins is an associate professor there. The second talk will be by Jennifer Head and Kristin Andrejko at UC Berkeley, who will talk about an individual-based stochastic model of school reopening strategies in the California Bay Area. And Jennifer and Kristin are doctoral students working with Justin Remais, who is an associate professor of environmental health sciences there. And then the last group will be by Dan Klein at the Institute of Disease Modeling in Seattle, Washington, who will talk about an agent-based model of school reopening strategies using the Covasim simulator developed by IDM, both in King County, Washington, and also more generally. Dan is a senior research manager at the Applied Math Center at IDM. So we're excited to have these 3 presentations. And then what we will do is, if people have questions for clarification, please put them in the chat or in the questions and answer. And then after each talk, we will briefly answer some clarification questions. And then we'll hope for the main questions to keep these at the end of all 3 talks. So with that, I will stop sharing my screen and I will ask Guido to give his talk about Indiana. Thanks, Guido.
Thank you, Wilbur. Thanks for inviting us, and I'm going to talk about our modeling approach to studying the impact of K-12 school reopening on the COVID-19 epidemic in Indiana. This is a team effort by many people in the Perkins lab at the University of Notre Dame. So first, students are going back to school in many places around the country, and it's not very clear what their impact will be in the burden of COVID-19. First, students are less susceptible, less symptomatic, and there are economic and social costs associated with the school staying closed, such as families having to stay at home to take care of their children. Children may not learn as effectively as they would in person, and some students actually will rely on school meals. So this is a difficult situation and a difficult question. We're addressing this in this talk and describing the model, showing the calibrated model and our reopening projections. So we use the FRED agent-based model that was developed by the University of Pittsburgh many years ago for flu. It is highly flexible and adaptable, so we adapted it for COVID-19 by modifying natural history of disease parameters and implementing some time-varying non-pharmaceutical interventions such as face mask adherence, sheltering in place, and others. So just a basic description of how the model works. As you can see here, we're simulating each individual in the population. Each individual, which is an agent, will have an activity space that is defined by their workplace enrollment, school enrollment, their house, their community, and if they are in any college or in long-term care facility. Once an individual is exposed to the virus, this person can be either infectious, asymptomatic infectious, or symptomatic. And symptomatic people may isolate themselves. They might develop severe symptoms and they could even die. So our model represents a realistic representation of the state, and we use RTI synthetic populations for this. And we have individual characteristics such as the household composition. We can have face mask adherence, sheltering in place adherence, their health status, and many other demographic characteristics. Each school has a classroom size, age-specific contacts. They have a geolocation, and for instance, a student to teacher ratio. I'm just showing here an example of what it is like in the Marion County with the demographic characteristics and also geographic characteristics. You can see the orange dots show the population density where we have all of these individuals placed, and the green dots show each school in the county. We had to include many parameters in the model. One of the most important ones are the severity by age. As you can see here, older people have a high probability of symptoms and a high probability of death, that is in this A and D panel. In the middle panels, we can see the probability of disease for every day and the cumulative probability of death. And we also have in our model the duration of infection and symptomatic periods. A very important assumption in our model is that children are less susceptible to infection. We base this on a study by Davis and others. And as you can see here by the black line that's in our model, where we're including that people under 20 years of age are much less susceptible than adults. And we have also an alternative assumption that susceptibility is lower even in younger children, that is all younger than 10 years of age. Time-varying non-pharmaceutical interventions were included in the model, mainly the percentage of people who stay at home and the number of people who wear a face mask. As you can see here, we based our sheltering in place trends on the Google mobility reports, and we scaled the magnitude of these trends up and down to represent how many people shelter in place for every day. In the right panel, we can see the face mask adoption, and for this we based the trends on the Google shopping trends for face masks, and the magnitude was scaled also in the calibration with a prior value based on a survey from the New York Times. Now we calibrated this model to 4 different types of data, mainly the incidence of deaths. So we can see here the gray line showing the model, how the model reproduces the daily deaths in the state. Not only we reproduce the age structure of the deaths, and as you can see in the right top panel, and we also reproduce the hospitalization and test positive ratios in the state. Here in the bottom left panel, you see an uptick in the hospitalization rates, but most recent data in the state is more consistent with our model in the sense that it's stabilizing. Other than calibrating our model, we use some data that we did not include in the calibration to validate the model. And there's a two serosurveys of SARS-CoV-2 in Indiana, and they show that approximately 3% of the population has been infected up to June. We can see here that without including this data in the model, our model is reasonably consistent with these results. It's also consistent in the right panel with the age structure of these results. So with the calibrated model, we proceeded to simulate some reopening projections. This is a worst case scenario. Is what would happen if schools reopen just as they did last fall in a pre-pandemic state. So 100% capacity and 0% face mask adherence. In the top panel, we can see that almost the reproduction number almost reaches 2, similar to what happened in spring. In the middle panel, we can see here that schools that are the green colors here had an important contribution to infection in spring, and well, they would similarly have an important contribution in this fall. In this scenario, we see that the bottom panel, the infections peak at around 70,000 cases, infections by day, which is very, very large, but this is a worst case scenario. Still, the question is still interesting. Why does the reproduction number increase if children are less susceptible than adults? So just showing here an example of our model where green colors show the infection in schools. So infections that happen in schools don't stay in schools. They have downstream effects to the communities. So you can see here how people in their household and adults in their households and in the community also get infected from infections that start in school. And we studied other scenarios, 3 scenarios of face mask adherence from 50% to 100%, and 3 other scenarios of school capacity, in-person school capacity from 50% to 100%. What we find is that operating schools at full capacity and with low face mask adherence could result in more than 5,000 deaths, which is represented here by this white bar, where the orange bar is what happens is school open without a face mask. So this is our worst case scenario. Best case scenario is what happens if it's fully online, fully remote instruction. And we see that capacity has a large impact in reducing the burden of COVID-19 due to reopening of schools. And we also see that face mask adherence all have an important contribution in reducing these deaths. This is in our baseline scenario, and I'll show a little bit of a sensitivity analysis on that assumption later. Another finding is that infections that happen in students, so this top panel here that shows that there are large infections in students in for instance, in this low face mask adherence and high and full capacity, they don't translate into deaths, that is the bottom panel here. But they do translate to deaths in teachers and their household members of students and teachers. So even if a large amount of students are infected, they don't necessarily are the ones who carry the burden of symptoms and deaths. So our baseline assumption was based on a non-healthcare setting study and around 0.3 adjusted odds ratio, but we also vary this to a high face mask protection that is 0.12, that is the left side of the figure here. And we can see that with a higher face mask protection, there is around a 70% reduction compared to the baseline scenario. But when we assume a low face mask protection of 0.73 adjusted odds ratio, this can translate up to 300% increase in the number of deaths compared to the baseline scenario. For all of these scenarios about capacity, 150, 75, and 50%, we see that there is an effect of changing the assumption of the protection of face masks. Another assumption that we wanted to check is what happens when if children of 10 years of age of younger are less susceptible than from 10 to 20 years of age. And these are represented here by the red dots. And so we can see here, they're very similar to the baseline scenario that are the bars, but we do see that there is a reduction, for instance, in this low face mask scenario with full capacity. So we think our results are reasonably robust to this assumption about susceptibility of children. And so what's going on in Indiana, what our understanding is that capacity might be around 85%, and there's a high face mask adherence. So it might be around this point here where the arrow is pointing. And we understand that there is a combination of remote learning, in-person learning, and a variation of capacity by day. And that the face mask is recommended for students in 3rd grade and above. Some limitations of our study is, well, first, the scenarios that we consider are a simplification of what actually would play out in reality. We, for instance, didn't include active testing and tracing of contacts, or schools closing because there's an outbreak. Our estimates are based on assumptions about the individual level behavior and contact patterns. And these estimates are also, well, the estimates of the impact of face mask adherence. They are sensitive to the efficacy of the face mask. And there is uncertainty about the level of infectiousness and susceptibility to SARS-CoV-2 among children. So with this, we can conclude that our calibrated model recreated surveillance data on deaths, hospitalizations, and test positivity, and it's consistent with results from 2 statewide serological surveys. Our results suggest an important early contribution of schools in SARS-CoV-2 transmission, and this same contribution could resume once schools reopen or no. And even with low face mask efficacy, we see that our results suggest that high face mask adherence could reduce the number of deaths, even if it's a low difference. Reduced capacity could reduce the burden of COVID-19 in schools and across the state, in-person capacity. And our results are reasonably robust to assumptions about susceptibility among children. Well, like to acknowledge our funding sources. And for more information, you can visit, take a look at our preprint that it's available on medRxiv right now. And thank you.
Thanks, Guido. So there was a couple of brief questions in the chat. One question is if the model is deterministic or stochastic, and what the population size is of the model.
Yes, so the model is stochastic. This is an individual-based model that has stochastic interactions, and the population is just the population of Indiana, which I think it's from 8 to 10 million, but I might be, I know it's around there, but I don't remember the exact number.
Great, and then one more question that was about clarification is, what did you assume about background prevalence in the communities for COVID-19, and anything about importations from the community?
To the schools?
Yeah.
Yeah, so I'm just gonna quickly go back here, right here. So we calibrated the model to represent first the dynamics of transmission in the community overall, right? And based on that, on the schools being closed in our calibration, we have people who get infected either in their workplace or in other parts of the community, and if they live with school-aged children, or if they are teachers, so they can import it to schools.
Great. Thanks. We have to move on to the next presentation. We'll hold the other questions for later, and maybe Guido later will put the link to the medRxiv paper in the chat so people can also look at additional detail there.
Yep.
So the next talk will be by Justin, Jennifer, and Kristin from UC Berkeley. So please go ahead, put the videos on, and yeah, up to you. Over to you.
Thank you.
Thanks.
Okay. Wonderful. Thank you all for the invitation. Hope everybody who's joining today as well and stays that way. Our efforts at Berkeley were led by epidemiology doctoral candidates Kristin Andrejko and Jennifer Head. And they set out on this work back in April with really tremendous wisdom, and in that they anticipated the very challenges we're facing today with respect to the appalling trade-offs we face between keeping schools closed versus reopening. And I say that as both a parent and of a kindergartner and as a scholar. So our work at Berkeley sought to achieve two things. One, look back at the spring to estimate the cumulative incidence in the Bay Area under counterfactual scenarios wherein schools remained open. So did school closures make a significant contribution to suppressing R0 and flattening the curve back in the spring? And then second, we estimated the effect of various school reopening strategies in the Bay Area for 2020 fall semester that is getting underway as we speak. Now, school closures and openings are blunt instruments with highly uncertain impacts on social contact. Children are often sent home from school to crowded intergenerational home environments. Some students and their families have more limited ability than others to effectively shelter in place, and students in some age groups have higher community contacts while sheltering in place than others. Think of the widespread adoption of pods for young children, for instance. So during this unprecedented moment of society-wide school closures and shelter in place, Kristin and Jennifer collected primary data on how social contact patterns of school-aged children and their adult family members were evolving in the Bay Area. And these data form the basis of the Berkeley transmission modeling effort. So let me turn it over to Kristin, who will say more about that and share some results.
Thank you, Justin. So there are three key steps we took to differentiate our modeling work. First, we knew we were, like others, reliant on robust estimation of social mixing, and we wanted to move beyond polymod as our main source of social contact patterns. Additionally, we wanted to capture the local social contact patterns of children amid an unprecedented long-term school closure and incorporate these data into our modeling. Second, after observing differences in the social mixing behavior among school-aged children during this period, we wanted to disentangle the relative effects of school closures by schooling level. And lastly, we knew a concern of reopening was how the decision would extend community transmission. So we sought to differentiate the infection dynamics between several key subpopulations, including students, teachers, household members, and the general community. To estimate age-structured social contact matrices for use in our modeling work, we have fielded a representative web-based survey to households with school-aged children in 9 San Francisco Bay Area counties, and we've done so cross-sectionally across May and August 2020. By surveying one adult and each child within a household unit, our primary aim was to understand how the frequency of in-person contacts with non-household members varied across study periods. We defined in-person contact as an interaction within 6 feet of a non-household member that lasted for longer than 5 seconds. To date, we have surveyed over 1,200 total households on behalf of about 1,700 total children. So here are the age-structured contact matrices estimated from our survey data and stratified by study wave. What you'll notice here is that the average number of self-reported non-household contacts per adult aged 18 to 64 remained quite similar across both study periods. But what's nicely and uniquely captured in our data is the variation in social contact patterns among children. During the first study period, we found evidence that elementary age students tended to have higher rates of non-household contacts than high school age children, perhaps as they were unable to stay at home alone and accompanied their parents on essential activities throughout the day. We also found evidence that social contact patterns across children are increasing between study waves, perhaps as parents have organized alternative forms of childcare. Here, we present age-structured social contact matrices stratified by 9 locations across the first wave of data collection when schools were closed. We want to highlight how the majority of non-household contacts between waves occurred at home, while performing essential activities, or at work. And we then compared how age-structured contact patterns vary by location and study period. So here I've just simplified the previous slide by comparing the age-structured social contact matrices at 3 of the 9 locations, and I've plotted the age matrices during May on top and August on the bottom. We found an increase in the non-household contacts reported at home in the second wave of data collection compared to the first, while the proportion of contacts occurring at work or while performing essential activities during the study period remained relatively constant. And this is in agreement with research out of the Berkeley Demography Department that has also found evidence of increases in self-reported number of non-household contacts reported at home throughout the pandemic. Lastly, we were interested in investigating the determinants of lower non-household contact rates. So we fit negative binomial models and found that significant predictors of reducing non-household contacts included being from a younger age group, a non-Hispanic household, and reporting contacts across the earlier study period in May. We're happy to revisit these results offline. I'll now pass it to my colleague Jennifer, who will describe how this work enabled us to create a synthetic population reflective of these characteristics.
Thanks, Kristin. So as Kristin mentioned, we coupled this data from our social context survey with other data from the census on household structure and employment rates, as well as school district data on classes and school sizes, in order to generate this synthetic population that represented major Bay Area cities. And this synthetic population was for use in our agent-based model. Within this synthetic population, agents were assigned membership into a household as well as an age, which determined whether they were classified as students, working, or non-working. Students were then assigned membership into schools, grades, and classrooms, while adults were assigned membership into a workplace. Some adults were assigned to classrooms to represent teachers, and some were assigned to schools to represent administrators and other staff. We then used a stochastic modified SEIR model that allowed for infected agents to be either asymptomatic, represented by A, symptomatic but not hospitalized, represented by C, symptomatic and hospitalized but recover, represented by H, and symptomatic and hospitalized before death, represented by D. Following entry into the hospitalization compartment, agents were assumed to no longer transmit to the community, but prior to being hospitalized, they were assumed to transmit to the community. An agent moved from the susceptible to the exposed class at a rate that was defined by the force of infection, which was unique to each agent, and calculated based on the contact rates with the infected agents, shown in the equation at the top. We included a term, here we call alpha, that permitted asymptomatic agents to transmit less effectively than symptomatic agents. The mean infectious rate, beta, was calculated using the next generation matrix method, assuming an R0 of 2.5. We permitted beta to vary based on age to allow different assumptions about susceptibility. In particular, we ran simulations where children under 10 were assumed half as susceptible to SARS-CoV-2 as adults, children under 20 were assumed half as susceptible, and all ages were assumed to be equally as susceptible. Following the latency period, the clinical course that an agent would follow was determined based on a series of random Bernoulli draws with the probability of success conditional on age, very similar to the last model. And waiting times between each compartment were determined based on random draws from a Weibull distribution. Next, to determine the time-dependent contact rate between agents I and J in our synthetic population, we classified each pair of agents according to their highest level of shared membership, whether that was household, workplace or class, grade or school. We used scaling parameters for these contact rates from previous literature on transmission in schools. All other agent pair interactions were classified as community interactions, and those contact rates were then determined based on the survey-derived age structure contact matrices. We multiplied these contact rates by time-dependent factors, which represented both our interventions as well as an intervention that permitted symptomatic individuals to quarantine at some probability. So first, we fit the model according to the observed contact patterns in the Bay Area between the start of shelter in place on March 16th and June 1st, which is the end of the spring semester. This top figure shows the observed contact patterns in the Bay Area over that time period. We validated our model by comparing our predictions to the observed data from the Bay Area on hospitalizations, deaths, and seroprevalence. These graphs are shown in the bottom, where the black data is representing the observed data, and the teal line is representing the mean of 1,000 stochastic realizations of our model. We then examined various counterfactual situations, such as if schools had remained open between March and June, as well as if other non-pharmaceutical interventions had not been enacted, such as if all workplaces had remained open over that time period or social distancing was allowed. So moving on to results, as of June 1st, the 9 Bay Area counties had reported a total of over 14,000 confirmed cases of COVID-19. We estimate that closing schools for the spring semester averted over 13,000 cases of COVID-19. However, we show that not all school closures contributed equally. We estimate that the impact of closing high schools and middle schools was more substantial than the impact of closing elementary schools. We also show that the impact of closing all schools was similar to the impact of closing workplaces in terms of the number of cases avoided. Taken together, all the interventions were needed to reduce the effective reproduction number in the Bay Area below 1. This can be demonstrated in the figure at the right, where the dark blue line shows a flattening of the curve and a decline in the daily number of cases reported. So as we mentioned, had schools remained open, we estimate that the Bay Area would have confirmed nearly twice as many COVID-19 cases than reported. However, we should also estimate that families with school-age children would have reported over 3 times more COVID-19 cases than were observed. This is shown in the plot to the right, where the box plot represents the distribution of the incidence rates under the counterfactual scenarios compared to the incidence rate under the observed conditions, where dark blue represents the distribution for households with students. We also estimate that had schools remained open, the Bay Area would have reported 663 more COVID-related deaths, and at the peak, an additional 1/5 of hospital bed capacity would have been occupied. Next, we tested a series of reopening strategies for the fall semester, including masks with quite low effectiveness, ranging from 15% among elementary students to up to 50% for teachers. Classroom cohorts with various levels of reduction in non-classroom contacts, hybrid schedules of 2 days a week, splitting the students both by grade and class, and testing of teachers and students at either monthly or weekly frequency, and isolating positive cases and quarantining the class for 14 days. We repeated each strategy against combinations of a high versus moderate community transmission scenario, as well as assumptions where children were assumed to be half as susceptible to SARS-CoV-2 as adults versus equally as susceptible. So moving to results for the reopening strategies, we estimate that a reopening scenario where no precautions are taken would result in a very high risk to teachers, students, and the community. In particular, under our high transmission scenario, we estimate that an additional 1 in 3 teachers, 1 in 8 students, 1 in 12 family members, and 1 in 16 community members in the Bay Area could experience COVID-19 infection and symptoms across the course of the 4-month-long fall semester. What is more, we estimate that over 1 out of every 100 Bay Area teachers could be hospitalized. Among high schools, we estimate that the risk is much higher than elementary schools. Across all transmission contexts examined, we estimate that the risk to elementary school teachers is 2 to 10 times lower than the risk posed to high school teachers. This plot shown shows the excess risk to teachers by school level across the various interventions, where the interventions are ordered by level of effectiveness. Across all the interventions, the risk in elementary school teachers is lower, but as you can see, the gap decreases as the intervention strength increases. We then examined which interventions were needed to reduce infection such that fewer than 1 additional % of teachers experienced symptoms over the fall semester. Those scenarios are colored green in the table shown for each of the transmission assumptions modeled. For elementary schools, we estimate that keeping kids in classroom groups of 20 students with minimal interaction with others outside their classroom, as well as universal mask wearing, was able to reduce risk below this threshold. However, for high schools, only a 2-day staggered schedule with stable cohorts of 10 students could reduce the risk below this threshold. Finally, we estimate that actions taken by the general community play a large role both in reducing the risks in schools as well as minimizing the chances that an outbreak in a school will seed a larger outbreak in the community. In our high transmission scenario, we assume that 75% of the population had returned to work in person and that socializing was at near pre-pandemic levels, while in the moderate, we assume that 50% of the population returned to work and socializing was moderate. This graph displays the estimated excess mean daily hospitalization rate across various reopening strategies and shows that in high transmission settings, a greater proportion of excess hospitalizations we estimate would be attributable, would be among community members compared to the moderate transmission setting. So we'd like to conclude with 4 main takeaways. First, our community survey found that children from Latinx households had higher community contacts during these long-term school closures than children from non-Latinx households, which suggests a more limited ability to effectively shelter in place and is aligned with other surveys and studies from the Bay Area showing higher transmission among Latinx communities in the Bay Area. At the same time, elementary school students had higher community contacts than high school students, also suggesting that these younger children have a more limited ability to shelter in place when schools are closed. We found that closing schools was important and a key step to flattening the curve early on in the Bay Area epidemic, and averted over 13,000 cases, much of which was driven by the closure of high schools and middle schools. Looking forward, we estimate that a reopening without any precautions could result in a substantial amount of risks, particularly to high school teachers, of whom 42% could experience symptomatic illness over the 4-month semester. While we do show or estimate that risk is lower in elementary schools, we still estimate that a combination of physical distancing measures are needed. And we estimate that these could be stable classroom cohorts of 10 to 20 students, as well as universal mask wearing. And we also note that lowering community transmission is also highly important to reopening schools. So thank you so much for your attention, and we'd also like to thank our wonderful collaborators on this paper, as well as our funding source.
Thank you very much. Wonderful presentation. Thank you. So we don't have much time, but I'll ask one quick clarification question, which is if you use the contact surveys to parameterize contact rates in non-community settings or not, I guess within the schools or not.
Right, so we used information on classroom sizes as well as school sizes, and then we drew the scaling parameters from previous literature. So the survey only parameterized community-based contact.
Community. Okay, thank you. Thanks a lot. I'd like to move on to the last presentation so that we have some time for questions, and at least so Dan can finish up his presentation. Dan, would you please take the stage here? Thank you.
Yeah, thanks for the kind invitation. And it's really great to see the presentations from the other panelists. I think you'll see a lot of similarities across the 3 different modeling results as I go through the work that we've done. This is work done in collaboration with Jamie Cohen, Dean of Mystery, Cliff Kerr, and many others at the Institute for Disease Modeling. I'll be telling you about the work that we've done. It's based in King County, Washington, but you'll see how we've tried to generalize the results. This is sort of the composition of 2 white papers that we've done, feeding into a longer publication that I can point you to throughout the publication. So I think we've been motivated by many of the same questions that have motivated the other groups as well. Seeing schools open around the world, sometimes without major outbreaks, other times not going as well, and just there being a lot of debate on both sides about bringing kids back to school. So we wanted to apply some of our modeling methodology to try to quantify some of the risks and educational costs of different reopening scenarios for schools in particular. And so we're using an individual-based model, much like the other groups. This is a stochastic model, and we've tried to capture all the various relevant pieces of COVID-19 transmission as part of this. So this is purpose-built. We're looking across the different parts of the model. So first, looking at the interhost shown in the top right there, you can see as individuals become exposed and eventually infectious, they can take one of 2 tracks. Along the top track is a symptomatic track in which individuals will pass through a pre-symptomatic period before entering mild symptoms, potentially advancing to severe and clinical symptoms. The bottom track is for those who might be experiencing asymptomatic infections. And related to a question I saw in the chat earlier, we have a larger percentage of younger individuals following along that asymptomatic track as opposed to the infectious track. All the transitions, as going to severe or critical conditions, are age stratified, and we're keeping track of the delays along each of those edges. The result is either death or recovery. These infections are acquired on a stratified network. It's also age structured. Perhaps much like the other groups, individuals will have households composed of close contacts based on data that is specific to the King County area. Adults can go to work, kids can go to school, infections can be acquired in the community, and as well, not shown in this figure, but important to the local epidemiology, is a representation of long-term care facilities that are in the model. Edges in this model are actually dynamic, so as we see shelter-in-place orders and things like that, we're actually removing edges from the network. Has implications on things like tracing. The reason to do all of this intricate modeling, of course, is is to be able to do setting-specific countermeasures such as schools and workplace reopening. Test, trace, quarantine kinds of things as well are carefully represented here, as well as the delays in each of those edges. Open source code if you'd like to take a look. So even to go beyond the basic model, we've made a number of changes specifically to address these school reopening scenarios. So these are structural changes and temporal changes to the way that the school layer operates. On the left, I'm showing some of the structural changes that we made from kind of having schools as a layer in the model, moving to a much more cohorted and structured setting. So in particular for the elementary and middle schools, represented by the yellow and green dots, you can see on the left how there was some classroom structure and teachers and staff represented in those structures, to cohorting where kids are actually, it's a structural change within the model to ensure that transmission is within these smaller cohorts within the model. We've not done the same kind of structural modifications for high schools, assuming that it's more difficult to implement cohorting type approaches with crowded hallways and things like that. Temporally, we've added the hybrid AB scheduling. Again, this is a modification where 2 days per week, half the students might be in class, say the A students Monday, Tuesday, B students Thursday, Friday, with the school potentially cleaned on Wednesday or something like that. So that will mechanistically affect the student-teacher ratio from about 20:1 down to about 10:1, as well as representing a phased-in approach where we're bringing back, say, just the elementary schools, or perhaps just elementary and middle, potentially leaving high schools remote so we can play with those different parts of the schooling system, as well as the non-pharmaceutical interventions modeled as well. So the NPIs like mask, ventilation, distancing, and hygiene, we didn't represent specifically in a mechanistic fashion in this analysis. We're assuming that those result in something like a 25% reduction in contact within the school setting, as well as we're doing symptom screening. It doesn't work particularly well, but symptom screening with follow-up testing for some, isolation, tracing, and quarantine of household members, as well as that school group. I think the other panelists have gone into this as well, but there's tremendous uncertainty around the role that kids play in transmission overall across susceptibility, symptomaticity, and infectivity. And so we've made similar assumptions that you've seen in the other presentations, around 2/3 reduction in susceptibility for those under 10 and 1/3 for those 10 to 20. And in sensitivity analysis, we make everybody equally susceptible. I mentioned the symptoms, so under 20, about half is likely to develop symptoms. And as far as infectivity, we've assumed that children are as infectious as others based on cycle threshold count publications, but in sensitivity analysis, we see if making those younger individuals less infectious makes any difference on the results. We have taken the model and carefully fit it to the local context here in King County. In particular, this was for the first analysis that we did. This is fitting the model to the number of diagnoses daily, taking in data on the number of tests, fitting to diagnoses, working with Department of Health on this, fitting as well to deaths, and trying to capture, as the other authors have as well, the age structure, because these patterns are quite important. And doing this kind of fit, it's not sufficient to just take the parameters off the shelf and plug it into a model like this. You won't get King County, so there's quite an exercise to get to this point. And in doing so, we have along the way structurally closed schools and implemented the shelter in place and the various phased reopening using mobility data from a cell phone provider, SafeGraph, as well as mass scale up in the area. And so one of the key uncertainties that we were looking at relative to mobility here is increases in mobility potentially following this analysis, and how that might relate to an eventual school opening, which was a couple months out at the time. And so here's the first set of results. We've titled "The Schools Are Not Islands" based on these findings. And what you see here is that you might be able to reopen schools without driving massive increases in the effective reproductive number if two conditions are met. The first is that the community transmission has to be low enough in the first place. So essentially, you want the effective reproductive number below 1 in the first place. And the second is that you have to have sufficient countermeasures in place within schools. So it's kind of a combination of the school-based measures and then what's happening in the community. I'll just very briefly walk you through the figure on the right. You can see across the bottom some of the various scenarios that were modeled. On left, moving from schools reopening as normal as they would have been last year, all the way to the right, it says no school, it really should be all remote. And then you can see the impact on the effective reproductive number. On the y-axis, taking note the bottom here is at 0.8, not at 0. And the different colored bars are for these different potential mobility scenarios. Of course, as mobility increases, even the base reproductive number increases, and you could see that in that blue bar, if there was a return to full mobility, that even with remote school, you could see we would have been in an exponentially growing situation. So there are quite some opportunities here. You can see in the salmon colored bars, mobility has remained around the 70% level. And there are opportunities here where, if schools are doing sufficient levels of non-pharmaceuticals combined with cohorting and at least symptom screening and sending home symptomatic individuals. We've also accounted for ILI, so it's not just COVID here. But we might be able to reopen schools, but there is a lot of uncertainty. And so since releasing those initial results with Public Health, King County and the Department of Health, many schools elected to begin the school year remote. And in the state of Washington, something like 95% of students are learning remote today. So we haven't really gone through the school reopening at this point, but wanted to follow up this analysis with some additional modeling work that brings in the hybrid scheduling that I mentioned earlier, as well as the phased-in approach to really try to quantify the risk in these more mitigated scenarios. So for this, to generalize the results a little bit further, many of the questions we got early on were like, this is great for King County, but how do I use this elsewhere in Washington and perhaps in other settings? Was to generalize the results. It's still set in a Washington King County substrate, but we're simulating now a slowly declining epidemic, so an effective reproductive number of 0.9. Worth noting that we're still not there. It's uncertain, but perhaps closer to 1 at this time. And then 3 different incidence scenarios, 20, 50, and 100 per 100,000, cumulative over 2 weeks. Note the 2-week period there. And what we find is that school reopening, as you saw in the other talks, is not zero risk. And so as we look at the proportion of schools that might have an infectious individual arrive on day 1, you can see it varies from about 5% up to as high as even 40%. And the higher number, of course, comes when there's more infection out in the community. This has nothing to do with the school-based interventions. This is just based on the population arriving at schools, kind of keeping track of the different school sizes, the number of schools, and so forth. So it really shouldn't be a surprise when we find infections in schools in the very beginning. The second thing was to try to pick this apart a little bit and look over the first 3 months of school reopening, what might happen to teachers and staff, and separately students regarding infections acquired or brought into the school setting. So what we find here is that, of course, the results again vary with the level of community case incidence. At worst, sort of up to a quarter of teachers and a little bit more than 15% of students could be present in school with an active COVID-19 infection. But that risk can be dramatically mitigated through the various scenarios that you see represented across the bottom of this figure. So on the left is all in person without countermeasures. That results, of course, in those large numbers, but moving to countermeasures, adding in the hybrid A/B scheduling, as well as then considerations for various structural changes, bringing back just elementary and middle, perhaps just the elementary or elementary combined with hybrid, which is just the K-5 and just 2 in-person days per week, does dramatically reduce the infection rate. And so essentially what we're seeing here is that the risk could be quite high, but they could be mitigated through some of these changes. In particular, bringing back the younger students first seems to make sense for 2 reasons. Both we're modeling that they're less susceptible to infection in the first place, and perhaps this is also higher benefit considering these individuals are less successful in remote learning. You've tried to quantify that by looking across these different scenarios. And again, what you can see here is that for the different dot sizes represent those incidence levels, and then the colors are the different scenarios we've considered. What I want to call your attention to here is just the difference between the different dot sizes. Again, points out the fact that what happens outside of schools is almost as important as what happens inside of schools. And so we need to work as a community to bring down these infection levels to enable us to increase, to bring back kids to school. And also important to note here is that the scenarios that have the least risk also have the least educational benefit, in the sense that students are benefiting less from in-person schools as we keep perhaps middle or high school students remote. So finally, we've looked how these sort of more nuanced settings might affect the community-wide effective reproductive number, as well as presenting some sensitivity analyses in this figure. So the purple are our baseline assumptions. We've modified the transmission rate in those younger learners, reducing by 50%, and you can see in green, that really only helps. And in orange goes the other way, assuming that everybody under 20 is equally as susceptible, that reduced susceptibility being key. We were concerned to the findings. And what you can see here is, of course, without countermeasures, school reopening ends up taking the effective reproductive number from our base assumption of 0.9 to a value considerably above 1 for all scenarios considered. But the other variants, which include NPI and potentially the various structural changes, don't result in driving the community to an exponentially growing situation. So general takeaway here is that the findings are, as in the previous presentations, robust to these changes. A couple key limitations I'd like to call out to this work. One is that we have made an assumption that students who are participating in remote learning are doing that. They're not out partying with their friends or whatever else, so haven't increased contact rates for those who are doing remote learning. And the second thing is a big assumption is that we're not modeling a return to work or community or increases in those layers of the model as children return to schools. This is something that we're not entirely sure what to do with, and perhaps we can have a discussion about this. The figure I'm showing on the right is looking at Department of Transportation traffic flows in the King County region, and you can see them coming down with the shelter-in-place order and slowly increasing back up. And there was some concern that, even as remote learning started here, that we would see increases in transmission or mobility. And of course, what you see in the red on the right there is decreases. That's of course relative to last year, so we're still seeing less mobility, perhaps just because the schools are not in person. Last thing to call out is that we haven't captured sort of the socio-educational inequalities. We know those are persistent and present, and they're not in this model. The takeaways, I think we've underscored the importance of community transmission, showing that this phased-in approach, bringing back younger learners first, might actually allow us to do a return to school in an incremental sort of way, bringing back those younger learners first because they're perhaps less susceptible and have higher benefit. I'll just leave on this slide points to some of the methodology if you'd like to learn more about this work or read some of the other papers. I've discussed most of these. The one at the bottom is additional. It's using the same modeling framework, but to look at school reopening in the United Kingdom. Thank you.
Thank you, Dan. Very interesting work as well. Really nice to see these three different studies like this. We have a few minutes for questions. I'll read some from the chat, but if people raise their hand, then we can allow some people to speak in the last few minutes. One question here that's not super technical is how often should testing take place for staff? Is there a cadence that makes more or less sense? Makes the most sense. Staff at schools, I presume. So Dan, would you, this was in response to your presentation, but maybe the others can also weigh in about the testing strategies.
Yeah, so in the current results that I've shared today, we haven't specifically modeled routine testing within schools. It's possible that something like this could happen in King County, but many of the other districts might not be able to implement such a high bandwidth testing. What we are doing is for those presenting with symptoms to have tests available, have them sent home and ask them to get tested in the community. We have separately looked at testing in schools, looking at different frequencies for teachers, most likely, less likely to be testing students on like a weekly basis or something like that. But comparing 1 week, 2 week, and a month frequencies, generally finding that you get a majority of the benefit with about a 2-week testing interval without needing to use quite so many tests. But welcome input from the other panelists as well.
Thanks. Yeah, does any of the other panelists have some ideas about the testing strategies for staff or even for the students?
We looked at 2 different testing strategies, one that was weekly and one that was monthly, and then we varied it by if it was just teachers or teachers and students, acknowledging that weekly testing strategies for both teachers and students is probably not feasible. And we actually didn't find that testing strategies was that great of an intervention compared to other non-pharmaceutical interventions. And I think it's because we assumed that symptomatic individuals were already going to quarantine with some probability. But we definitely found that the weekly testing had more of an impact than the monthly testing, although we didn't look at specific intervals to see where the most gains were achieved.
All right, thank you. And then a last question that maybe all of you could answer briefly is about, this is more a question I came up with. There's no questions, no hands are raised here. But and how much, to what degree have the school districts or health departments in your areas looked at your models for their strategies? Has there been any interactions there? Maybe Guido can go first on that one, and then Dan, and then the Berkeley group.
Alex, maybe you want to respond to this?
Sure, I'm happy to. So when we did complete our work, we communicated it to the state of Indiana, and they have followed up with us, and we've presented it to a couple of different groups within the state health department and others working on it. You know, I think to a fair degree, our results support a lot of the measures that they're already enacting in terms of requiring face mask use in schools. In terms of operating capacity, which is the other main factor that we looked at, there's a wide variation across districts in terms of what's going on, but at least overall across the state, it seems that they're not operating at full capacity. It's down maybe about 15%, like Guido mentioned. So I think they found our results as probably somewhat reassuring, but we'll see where things go from here as data comes in, unfortunately.
Great, thank you. Dan, how about you?
Yeah, so we've worked throughout the development of this work closely with the King County Public Health and also the Washington State Department of Health. You know, there's lots of considerations that went into some guidelines that the Department of Health put forward. They call the decision tree, kind of breaking incidents down across different levels, looking at under 25 and 25 to 75 and 75 above, kind of different risk categories, what their recommendations were as far as bringing students back. And we had some input into that. That's at the state level. Those are just recommendations, and really these decisions are up to each of the local school districts. And as I mentioned in my talk, many of them have elected not to bring students back just yet. We've shared these work. There's a weekly DOH modeling group, which is really great to see. Perhaps some of the other groups are participating as well, but really embracing a lot of the modeling work and the decision making.
Great, good to hear. Thank you. Yeah, the Berkeley group. Anything over there with the school districts or the health departments?
Very similar interactions on our end. We had wonderful discussions with California Department of Public Health right as California's Governor Gavin Newsom was establishing statewide school policy, which is really a set of guidelines similar to Dan describes that are actually, you know, subject to district level decision making. And so there's been some discussion with local districts, but most of them are being guided, one, by their risk aversion, and no public school district in the Bay Area has opted for initiating reopening, and two, the infrastructure needs are making these decisions for districts. They simply are not ready with respect to even the fundamental mitigation strategies they would need to employ by all consensus of all models, but also guidance they're receiving from CDC and the state. So that means that the reopening will likely occur on a timeline by which filters are in, filtration systems and ventilation there is established in classrooms, rather than be guided by kind of data or input that's coming in from modeling work in real time.
All right, thank you very much. We've reached past the hour. I really like this, the way we did this time. Thanks, Alex, to suggest the format for the seminar. And thanks everyone for joining. Also, all the participants for listening. This is being recorded. You recorded this webinar, so it will be on the MIDAS website. And also, we have a YouTube channel for MIDAS where we put all kinds of videos together and put videos that people have been appearing in. Yeah, thanks. I hope to see you guys soon again sometime, and have a wonderful weekend. Thanks, everybody.
Thank you.
Thank you, Wilbert.
Thanks.